Okay, hi everyone. Welcome back to our multiple imaging lecture series. It's a great pleasure today to introduce Dr. Randall Thompson. He works at St. Luke Cardiovascular Institute. He is the president of the American Society of Nuclear Cardiology. He's a professor of medicine at the University of Missouri in Kansas City School of Medicine. And we're really looking forward for his lecture. It's a great pleasure to have you here. Thank you, Dr. Thompson, for joining us.
Thank you, Dr. Bustamante, and thank you, Dr. Travin and Dr. Garcia, for the invitation. I saw the list of luminary speakers you've had on this series, and I'm honored to be part of it. I have no disclosures. I like this concept slide, so I'm going to talk about nuclear cardiology in particular today and testing for our patients, mostly with coronary artery disease. And I like this concept slide from the ESC guidelines from 2019. And the thought is that when someone is really low risk, low probability, they don't need any testing. Or maybe if they're not quite super low, they perhaps just do a terminal exercise test or maybe a calcium score. And if on the high end of the spectrum, then invasive angiography is appropriate. You don't need a stress test to know if someone's got acute coronary syndrome. You need to know if they what their coronary anatomy is. And in between, there's a pretty big gray zone where there's some overlap of cardiac CT and the nuclear, and in Europe more the MR techniques. And we discuss which is, where do you draw the line between those two tests and what's best for the patient and so forth. And I have friends that are enthusiastic about cardiovascular CT, and they'll draw the line way over here. I'll say, really, we ought to do almost everything with cardiac CT, and nuclear has a very defined role for just patients that have known disease where you're trying to establish how much ischemia there is. And these people generally are enthusiastic about CT, and they think that CT-FFR is the greatest thing since sliced bread, and they probably are comparing it to 1990s nuclear. And there are places where one modality is a whole lot better developed than another, and I can sort of see that. On the other hand, some of us, like me and my place, even though we have fine CT scanners, would draw the line of overlap way over here, thinking that really nuclear, the way you do it today, the way we do it with PET and so forth, ought to be the dominant go-to modality, and CT is really for the more low-risk patients. And people who fall in this camp are like us, where a lot of our patients are old, they've got established disease, and we're pretty sure that CT-FFR is not the greatest thing since sliced bread. Anyway, as Dr. Bustamante said, I'm in Kansas City, which is right in the middle of the map. And nearby Kansas City is a little town of Chillicothe, Missouri. And Chillicothe advertises that they're the home of sliced bread. Apparently it was invented there. So we can say from the Show Me State that we have become by skepticism naturally, and we also know something about sliced bread. Anyway, before I talk about imaging, let me just kind of touch on the issue of exercise testing and remind all of us how powerfully prognostic it is. We have just oodles of studies. This is one of the larger ones. And as you see, as your peak O2 uptake goes up, probability of all-cause mortality and cardiovascular mortality go down in a curvilinear fashion. So it's extremely powerfully prognostic, very helpful to reproduce someone's symptoms. And that's one of the advantages of treadmill testing and SPECT, is that you can get exercise with it. It's hard to do that with PET. With ammonia PET, you can, although most places do not. They use pharmacologic stress. Other PET is pharmacologic stress, as is stress echo much of the time, and MRI. So it's something to keep in mind. Now, when I talk about nuclear cardiology in 2021, not old-fashioned nuclear, the up-to-date version includes up-to-date SPECT instrumentation. The older cameras don't give you as good image quality. We do a lot of stress-only attenuation correction with a low radiation dosage. We combine NPI with coronary calcium score more or less routinely, and I'll talk a little about that and how you can do it even if you don't have a CT scanner quite handy. PET myocardial perfusion has a lot of recent research on it, and it's a great advance in the field of cardiovascular imaging. And then PET quantitation with blood flow myocardial perfusion is a major advance and gives tremendous amount of prognostic information. and coming are actually here now and sort of rolling out as a digital PET. We have a scanner, and Dr. Travis said that you all are hoping to acquire one soon. Inspect quantitation of blood flow, which has been being done clinically in some places, and I think is the future of nuclear cardiology. In terms of the equipment, all of the camera manufacturers have improved their instrumentation over the last 10 years. Better sensors, better detectors, iterative reconstruction, resolution recovery, routine use of attenuation correction, and so forth. The advance that's been studied the most are the CZT crystals. These are scintillation crystals, which are much faster, a design of a camera that allows much more efficiency of the counting. And with this, you get sharper spatial resolution, much faster image acquisition, or lower radiation dosage. And indeed, at this point, we have meta-analyses showing that CZT cameras are more accurate than conventional imaging. Here's one meta-analysis, 40 articles, 25 with conventional SPECT and 15 with CZT SPECT. And you can see the ROC curves. There's a little better area under the curve for CZT SPECT. Sensitivity and specificity are likewise a little bit better. But you combine that with the fact that the cameras are faster, you can give less radiation dose, and there's a substantial advance. And here's the conclusion of the authors, that C-SPECT and CZT SPECT have good diagnostic performance in detecting angiographic proven CAD with a slightly higher accuracy for CZT SPECT. This results support the use of the novel gamma cameras in clinical routine practices, also considering the improvements in acquisition time and radiation exposure. Indeed, and one of the reasons we've been able to bring the radiation dose down so low in our facilities is because we do a lot of imaging with the CZT cameras, a lot of stress-only imaging. There, in many of those cases, we get the dose down to about 1/10 of the usual dose. So the usual rest stress SPECT study is about 10 or 11 millisieverts. The average background radiation in the United States is about 3 millisieverts per year. And our average dosage in our laboratory is well under 3 millisieverts, about 1/3 of the benchmark of 9 millisieverts. So let me move on and talk a little about other things we do in 2021. Here you have a nice normal myocardial perfusion imaging study. Stress is on top, rest is on the bottom. It's a nice homogeneous study. It looks nice and normal. And what we would have said for many years is that, well, your prognosis is good. You don't have obstructive coronary artery disease causing symptoms, and therefore good news. Well, what if you also did this and knew the patient had a coronary calcium score that's extremely high, in this case, 3,457? Well, then you would treat the patient differently. You would say, well, you do have significant atherosclerosis. This is not just a marker. This is the disease itself, the old rotted crusty plaque that's that you've detected here. And this person, in our opinion, ought to be treated with different follow-up algorithms. When the symptoms change, they ought to be reevaluated. Most of them that have normal myocardial perfusion, such as the scan, are true normals, but they have severe underlying non-obstructive disease, and they warrant risk factor modification and so forth. And we've known this from many studies. This one's one of the larger ones, 25,000 plus patients, followed over 10 plus years. You see the all-cause mortality based on coronary calcium score is in a direct relationship to the amount of calcium. And that's because we are measuring atherosclerosis. You're measuring how much atherosclerotic disease there is. That's why it's so powerfully prognostic. And what we do, what many labs do, is we combine this with the myocardial perfusion imaging study routinely in patients that do not have known coronary artery disease. And that improves the diagnostic capacity of the study, as well as the prognostic content of the study. Now, here's one example of improving diagnostic value. You see in yellow the combined SPECT plus calcium score plus the Framingham risk score, more accurate than calcium score or SPECT without it. And it's probably even more accurate, more of an incremental improvement in accuracy than this shows. Dr. Trevor and I were speaking about it. When you have a calcium score of 0, you tend to read for specificity. And when you have a calcium score that's high, you tend to read for sensitivity. I think that's okay. That's you're behaving in a common sense manner. Here's one of several studies showing the improved prognostic value. If you have an ischemic versus a non-ischemic myocardial perfusion imaging study, the annual event rate is higher for those who, based on the rate of increase in your coronary calcium score. Here it is in Kaplan-Meier curves, abnormal spect on the left, normal spect on the right. The higher the calcium score, the greater the event rate at every level you look at. And that's true for both SPECT and here with PET. In this study that was recently presented at the American Society of Nuclear Cardiology scientific sessions, as your amount of calcium goes up, the prognosis is particularly more significant when you have ischemia by perfusion defects. By the way, in many places, it's easier to get a coronary CT angiogram than it is to get a coronary calcium score. And one of the purported benefits of a coronary CT angiogram is that you diagnose underlying coronary artery disease. Well, in reality, the prognostic content of your CT scan is mostly in the calcium score. This is a study from earlier this year, and what they showed that on a series of patients with coronary CT angiograms, that the calcium score was as predictive as with obstructive lesions by CTA or without. And that was true if the calcium score was 0, if it was mildly elevated, moderately elevated, or severely elevated. The curves are pretty much superimposable based on calcium score, whether you had obstructive lesions or did not have obstructive lesions. Here's their central figure, and their conclusion is that plaque burden, not stenosis per se, is the main predictor of risk of cardiovascular events and death. Thus, patients with a comparable calcified atherosclerotic burden generally carry a similar risk of cardiovascular events, regardless of whether they have non-obstructive or obstructive CAD. Isn't that interesting? We thought it was the number of stenoses, but it's really the disease burden plus the effect of that burden that's so important. The other thing about this is the physicians do change medical therapy. We can't prove that the change in this therapy makes a difference in these kinds of patients, but we believe it does. And most doctors act on it. We've been showing these slides for 10 years now. So when you add coronary calcium score in patients who are undergoing stress testing, it detects subclinical disease, and patients can be referred for proper follow-up algorithms and risk factor modification, improves risk assessment, improves the accuracy and detection of patients at the highest risk, and leads to greater changes in management. Now, you don't have to have a formal coronary calcium score. And it turns out that in our field, to get a CT scanner that can score the calcium costs more money. You have to buy a higher end scanner. You have to get a software package for calcium scoring that costs in the range of $50,000 or so. But you can eyeball the calcium, and that's almost as good. Here's a study we did a few years ago where on the left is the visually is the non-gated CT scan done for attenuation correction for a PET or SPECT study. On the right is the calcium score. And the top is someone who has significant calcium, and the bottom is someone who has none. And the line of the vertical line here is the line of identity between the visually estimated calcium score and the formal Agassiz calcium score. Most of the patients are along this vertical line of identity, but the more patients are underestimated than overestimated visually, which kind of makes sense, especially in obese patients. You may not be able to see it well if the calcium is blurred, but it's pretty good. You can train your eye to do this. In fact, you don't even have to be an expert to train your eye. Here's a nice study that came out recently from Intermountain Health. And what they showed in this fairly large study is that visually estimated calcium score was an independent predictor of MACE, and that the visually estimated calcium score can be used to improve risk stratification and prognosis without radiation. And their categorization was pretty broad. It was just absent calcium, equivocal calcium, present or extensive. In other words, just thumb up. What does it look like? An eyeball was a quick look. And you can do this yourself if a patient has had a CT scan on your electronic medical record. You can look up the scan. You can look, even if the radiologist may not have called it, you can look to see, well, was there calcium in the coronaries? Is there calcium in the thoracic aorta? Is it none I can see? Is it a little bit? Is it a lot? And you can risk stratify patients based on that. And they added it to the level of ischemia based on some stress score. And as you have increasing levels of ischemia, Those that have the most extensive coronary calcium are the ones that have the worst prognosis and the most events. And it's true for all the group, those with normal perfusion, those with abnormal perfusion, those with no history of CAD, and even those with a known history of CAD. I thought that was interesting because if someone had a stent and you can see a lot of calcium on a non-gated scan, they have a worse prognosis than if you don't see a lot of calcium. I guess it kind of makes sense, but I never had thought about it before. You, instead of using your eyeball, and I've gotten pretty good at being able to estimate calcium, but I'm sure a machine would be better than I am. There are some new AI solutions for this. In fact, one of the hats I wear is to represent cardiology on the CPT editorial panel for the AMA, and there'll be a new emerging technology category 3 billing code in July for an AI solution so that you can put your non-gated CT scan through this computer algorithm and get an estimated calcium score, undoubtedly better than your eye. There's one exception though, and I was writing an editorial about that study from Intermountain Health, and the next day I had a patient who had a calcium score of 121 and subsequently had a non-gated CT scan as part of an attenuation map for a SPEC study, and you can't see it. So this person now is a BMI of 40. So in these very heavy patients, and we certainly have our share of them in Kansas City, and Dr. Travis tells me in the Bronx you have your share as well. You may not be able to see it, and that's sort of the exception. The moderate calcium in someone who's obese, a non-gated study may just be unidentifiable. So let me move on and talk a little about PET myocardial perfusion imaging. That's really the best type of test we have in nuclear cardiology. This higher resolution than SPECT. It has robust attenuation, better flow tracers, better overall accuracy. In addition, you get other information about the heart. You really can interrogate the patient's heart with the ejection fraction reserve and quantitative flow and coronary flow reserve. This is a prognostic study, a multi-center trial of cardiac PET. Indeed, the more ischemia that you have, the worse the prognosis, the number of events you have with both SPECT and PET, now shown with PET in a number of studies. We do have meta-analyses comparing PET with SPECT, and PET, indeed, the better spatial resolution and these other advantages do translate into more accurate diagnoses compared to angiography. Here, a meta-analysis of 5 studies. PET in the Pacific study is more accurate than both SPECT and coronary CTA. Now this is with O15 water, but I believe this also translates to rubidium and ammonia PET imaging that we do. And let me show you some examples. Here's a patient who is obese. She's a female with large and heavy breast. Here's a SPECT study. If you're not used to looking at them, the stress is on the top, the rest is on the bottom. There's a defect here on both rest and stress. It doesn't particularly, looks like it get better. And it's hard to say, does this patient have ischemia or not? Is this just soft tissue attenuation? So we repeated the study with PET, and this is not even a particularly up-to-date PET machine, but you can see there's a large, severe reversible defect on the stress images that's not there on the rest images. The attenuation correction with PET is very robust. And in this case, we've made the proper diagnosis of a large area of ischemia and significant disease we otherwise would not have been able to make with SPECT. Let me show you another example. This is a patient with a small body size, small heart. This SPECT study is hard to read. In this case, it has to do with the spatial resolution of SPECT. You can kind of see a reversible defect here at the base. Makes you wonder, did the heart dilate a little bit? So we repeated this with PET. And again, this is not even a particularly up-to-date PET scanner or even beautiful PET images, but no question, you've got a large and severe reversible defect at the base anteriorly. The heart dilates with stress. Now, this was the grandmother of one of my office employees, and the coronary angiogram showed a severe left main stenosis. You hate to miss left main stenoses, especially you hate to miss them in your and relatives of your employees. And you can see from the LV-gram, just the person really did have a small hyperdynamic left ventricle with a small cavity size. In this case, it was an issue of spatial resolution. I'll show you one more case, also issue with spatial resolution. I'll tell you up front, this person has a high-grade stenosis and an obtuse marginal branch of the circumflex coronary artery. This is the SPEC study, again, kind of a small heart. You kind of see something here at the base, but it's pretty subtle. And here's the corresponding PET scan done a few days later. There's a severe, very obvious defect. In the circumflex territory, by the way, is the furthest from the camera and the most challenging part of the heart to see with SPECT, but it's very obvious with PET. So you see this sort of advantages even with machines that are vintage of 10 years older, and we've got newer, more advanced equipment even now. Let me turn and talk a bit about the principles of absolute quantitation of myocardial blood flow. So the terminology is sometimes confusing to people. You're talking about flow. Well, in the static, in perfusion flow, and in the myocardial perfusion image, a flow image, well, it is, but now we've added the time domain. So we have an input function. You draw a region of interest around the heart, and what you get is milliliters of nutrient blood flow per gram of myocardium per unit time. And we measure that at rest, and we measure it at stress, and then we get a ratio of stress to rest myocardial blood flow. And ratios tend to be forgiving, just like the ejection fraction is. And that's what we usually go by, is the ratio of rest to stress. And the magic number is 2. One should at least double their myocardial blood flow in absolute terms to be normal. And it turns out this is an extremely powerful prognostic parameter. So it helps detect pharmacologic non-responders. So if you think about it, if someone had a pharmacologic stress test and they had drank caffeine and they didn't tell you, then the caffeine might interfere with the stress agent. You might be looking at 2 rest scans, and how would you know? Well, with quantitation of myocardial blood flow, you can measure whether they did increase the flow like they should have, and tell. It improves the detection of severe coronary disease because the prognostic power of the flow reserve number, and the added prognostic value. And here's how we bill for it. As of last year, there's a new CPT code for it as an add-on code. So it's sort of declared ready for prime time based on the AMA CPT editorial panel and the RUC process. Here's a study we've been showing for a number of years. As the coronary flow reserve goes up along the horizontal axis, the probability of 3-vessel coronary disease goes down in a curvilinear fashion. So if your flow reserve is over 2 or 2.5, the odds of having severe coronary artery disease get lower and lower. Here are 3 studies showing the incremental prognostic value compared to the myocardial ischemia. On the left is out of Ottawa, Canada. The top right is out of Texas, and the bottom is out of Boston. In each of these cases, the worst patient category are those who have significant ischemia and an attenuated coronary flow reserve. And it's true for based on however you measure it in these studies. And in the Murphy study, also true with ejection fraction. Patients who have low ejection fraction and flow reserve have the worst prognosis compared to others. Here's a study from our lab. Krishna Patel did, and now we've got over 12,000 patients. Most of these, we were not looking at the flow reserve or not integrating into the report. So people didn't act on them. And the best group to be in is if your flow reserve is above 2. They did better than those who were intermediate, who did better than those who had a flow reserve less than 1.8. And you see this is all-cause survival, big difference in the numbers, really a dramatic difference, dramatically prognostic here. And this is true for the overall population, those who had no ischemia, those who had a little bit of ischemia, and those who had a lot of ischemia. And the worst group to be in is those who have ischemia based on perfusion defects and those who have a flow reserve that's abnormal. Krishna also put together this curve of probability. So what about patients who are treated medically versus those who are treated with early revascularization? Along the vertical axis is hazards of cardiovascular death, and along the horizontal axis is the blood flow reserve. At about 1.8, there's a crossover of patients treated medically versus those treated with early revascularization. So if your flow reserve is low, you do much better with early revascularization than with medical therapy. And if your flow reserve is high, you do increasingly better with medical therapy versus early revascularization. Isn't that interesting? I'd like to be able to confirm that perhaps in a randomized trial, but it suggests that indeed we are measuring something that's very powerfully prognostic, that's very important. So let me show you some example cases of how we've used the flow reserve. Dr. Travis says you all have that and have been reporting flow reserve for some time. This is a 47-year-old smoker with dyslipidemia who's in with some equivocal chest pain and equivocal troponin. He was a behavior problem. He was always out of the nurse's desk and driving him nuts. He'd had a treadmill test a couple of years before that was negative, and he was referred for a PET scan. And here's the black and white set of images. It looks pretty good. Maybe here the apical septum, there's a little something reversible, maybe it's pretty subtle. Here it is with color, likewise, pretty normal looking. It's really, what we see there is so subtle we wouldn't call it by itself. But with the PET scan, we interrogate the heart very thoroughly, and his flow reserve is severely attenuated. I told you that the magic number is 2, and he's well below that. So his flow reserve is severely attenuated. It looked like the quality control was appropriate. His ejection fraction did not go up. So with pharmacologic stress, with PET, the EF should go up. You're acquiring the images during the stress itself. And regonicin, diapramol, and adenosine are vasodilators, and generally you get an increase in the EF. And this patient did not. He got a drop in the EF slightly. And his coronary calcium score was over 400. So I guess I'd ask you, thinking ahead, what would you do next? Would you send him home with medical therapy, do a cardiac catheterization, do another stress test? Well, what happened has changed my practice to the point that I now always get the attending physician on the phone or in person to tell them the results when there's so much information like this. So what happened was that the information was properly communicated, but it was to an intern or someone inexperienced who passed on the message that the static perfusion images look good. On a busy Friday afternoon, the answer was, great, this patient's driving the nurses nuts, let's let him go. And he came back 2 days later with an occluded right coronary artery. And the patient did okay. He had some other disease in the left system, not too bad. He had an intervention and did okay. But we think in this guy's case, the problem was caffeine. We think it had caffeine on board, and we were really looking at a rest scan plus another rest scan or attenuated stress scan. The study was reported correctly, but it does bring up the issue of communication. And in fact, every time I've been to an M&M conference, it seems like one of the conclusions is we needed better communication here. Anyway, this patient did have enough abnormalities which raised concern about his heart. And the effect of caffeine is sometimes underappreciated. We did this study a few years ago with regonicin. Regonicin is a stress agent we use that has fewer side effects and is more specific. And we used to think that it had such receptor reserve that you didn't have this problem with caffeine, but now we know otherwise. And in patients who had what's really the equivalent of a couple of cups of Starbucks, really kind of worst case phenomenon, the number of defects on the first stress image was substantially more than those after caffeine. So it is a real effect. This is a problem, and that's one of the benefits of flow reserve is we can detect this when it happens. Let me show you another case where flow is helpful. On the left, you have a normal myocardial perfusion imaging study, pristine normal, beautiful images. And the flow reserve, as you see, is well above 2. It's 3.38, normal in all segments. And there's no coronary calcium identified on the limited field of view CT scan. So I'm going to ask you the question, does the patient have coronary disease? No, that he's not. Don't even have any calcium. Does the patient need revascularization? No. In fact, Dr. Travis says that that's oftentimes what he's telling the cardiology trainees the goal of our MPI study is to help to identify whether there's enough ischemia to warrant other treatments. Does the patient have adequate stress? Yes, the flow reserve is nice and high. And does the patient have microvascular disease? Again, the answer is no. You've ruled out microvascular disease. So if the patient has symptoms, you should go on to a different organ system. Here's another patient who had stable angina. And if you look at the images on the left, there is a reversible defect here inferiorly. It's not very big. It's kind of moderate intensity. And so, under 10% of the myocardium. And here your flow reserve, it is abnormal in the right coronary territory, but not severely. It is normal in the LAD, and it's kind of borderline in the circumflex territory. So I'll ask you those set of questions again. Does the patient have coronary disease? Yes, and it's not big league. Does the patient need revascularization? No, based on the size of the defect and the normal absolute quantitation of myocardial blood flow globally. The regional flow reserve did confirm the local area of ischemia, though. Was it an adequate stress test? Oh, yes, indeed. The flow reserve, global flow reserve is above 2. And is the microvascular disease? The answer is no. Let me show one more patient where I think flow helped us. This is a patient who has truncal obesity, hypertension, heart failure, preserved ejection fraction, the metabolic syndrome, has that phenotype. The perfusion study, static perfusion study on the left is nice and normal. And she underwent 2 tests. The first flow reserve showed was 1.19, abnormal in all segments. The question was, did this patient have caffeine or not? We thought she did not, but we went out of our way to hold caffeine, made an extra effort, and then repeated the test. And the flow reserve was not 1.19, it was 1.20. This patient has microvascular disease. So she meets the phenotype. She has the kind of heart failure, ejection fraction, hypertension, truncal obesity, and so forth. And this overlaps with microvascular angina. And so in this case, does the patient have coronary disease? No. Does the patient need revascularization? No. Does the patient have inadequate stress? I say yes, we repeated this twice to prove it. And does the patient have microvascular disease? Yes. Now you've made that diagnosis. Now, this diagnosis of microvascular disease is one that, at least where I work, is becoming greater recognition. I used to think of this as something that was kind of an ivory tower diagnosis, or maybe a few specialized centers had clinics for it, but we've opened up our own clinic for microvascular angina. So these patients are categorized properly, treated by folks that have an interest in it, and so forth. And what we're measuring with our flow reserve measurement is not the same as what you measure with FFR in the cath lab or CT-FFR. We're measuring the whole myocardium. And so that resistance to flow could be from diffuse macrovascular disease, the medium-sized vessels, or the small vessels. This issue of microvasculars, I understand that you all had Viviana Ticchetti speak. I suspect she covered this, but as you remember, it's associated with an adverse prognosis. Most patients with it also have macrovascular disease, so it's not usually in isolation. And it overlaps with obesity, insulin resistance, heart failure, preserved ejection fraction, and angina with no obstructive coronary disease. And it is a target for novel interventions, some of the diabetes drugs and so forth. And this concept curve from Dr. Ticchetti's paper, I think, is very helpful. As the severity of microvascular disease goes up, the clinical risk goes up, and there are overlaps with patients that have focal disease, mixed focal disease, and diffuse disease, and those who have just severe microvascular disease. So in other words, an abnormal flow reserve is not specific for obstructive coronary artery disease. In one sense, you're measuring flow quantitation the way you are with FFR, but in another sense, you're measuring something different. You're measuring the whole myocardium. So there are some emerging applications for myocardial blood flow reserve, in addition to the obvious ones I showed you in terms of determining pharmacologic non-responders and prognosis, and that's in cardiac allograft vasculopathy. So for the patients that you have who've had cardiac transplant, this appears to be an emerging tool that might be quite helpful and perhaps can allow us not to do as many coronary angiograms in those patients. It's prognostic in patients with non-ischemic cardiomyopathy, helpful in those with heart failure, preserved ejection fraction, hypertrophic cardiomyopathy, aortic stenosis, and perhaps in helping to diagnose cardiac amyloid. This is a recent study on the issue of using PET flow reserve to help with follow-up of patients who had heart transplant to diagnose graft vasculopathy. Conveniently, there were 25 patients who had an abnormal flow reserve and the 25 who had a normal flow reserve. Those who had an abnormal flow reserve had a significant drop-off in mortality over just a few years. We don't know yet whether This can be used to avoid coronary angiograms, or how often it can be used. And we don't know when there's a drop from one year to the next, how big a drop is important. So more work is needed on this, but it looks promising and emerging. Myocardial flow reserve appears to be offer prognostic value in selected long-term heart transplant recipients and holds promise as a non-invasive method for cardiac vasculopathy surveillance, possibly guiding medical management. And I'll call out one other study regarding non-ischemic cardiomyopathies and ischemic cardiomyopathies from my center, from Randall Thompson. She found that in this retrospective review of patients who had an ejection fraction under 40%, there was a high mortality in both groups, especially the ischemic cardiomyopathies, and that myocardial flow reserve was prognostic of death similarly in both the ischemic and the non-ischemic cardiomyopathy groups, and reversible defects in EF reserve were not prognostic, interestingly. Here's the point estimate and the confidence interval. So if someone has a non-ischemic cardiomyopathy, even with no obstructive coronary artery disease, if they cannot augment their coronary flow with pharmacologic stress, that's a bad prognostic feature. And you can think of mechanisms why. Maybe there's more fibrosis, maybe the myocardium is sicker, even out of proportion to the ejection fraction, and so forth. And then I will call attention to one study where flow reserve might be helpful in diagnosing cardiac amyloid. In patients who have left ventricular hypertrophy from the usual cause, the flow reserve tends to be much higher than on those who have cardiac amyloid. So there might be a tip-off if someone perhaps has heart failure, has an MPI study. The PET scan shows diminished flow reserve. There might be a tip-off that you should look for amyloid in those kind of patients. Let me move on and talk about digital PET. Dr. Travin mentioned that you all are hoping to acquire digital PET sooner. This takes this to yet another level. It's about twice the spatial resolution. The counter systems are thinner, more accurate. These patients have, these machines have even more robust attenuation correction. So I think the weight limit on our machine is 500 pounds now. So for these obese Midwesterners that we see, it's nice to have a tool like this. Here's an example. You've seen the images that I've been showing, and you can kind of tell from this that we have twice the spatial resolution. Beautiful images. You can see the papillary muscles and so forth. We believe this translates into more accurate diagnosis, finer diagnosis, more precision. This patient has, you see, a large, severe reversible defect. He'd had restenosis and an LAD stent and had kind of atypical symptoms, but this led to its proper diagnosis, and he obviously has a high-risk scan. The other way that I've used these digital PET systems recently is those with super morbid obesity. So one day I had two patients that were referred for evaluation who had a BMI of 48. The first was this 36-year-old who had uncontrolled hypertension, a new diagnosis of congestive heart failure, and had a troponin leak. It was thought most likely the troponin leak was caused by accelerated hypertension and so forth. And he was referred for a coronary CT angiogram. He had a BMI of 48 and a heart rate of 100. And so we talked to the team and said, why don't we do a PET instead? And we changed it to a cardiac PET. And this is what you have. This is not as pristine image as the other patient. But for BMI 48, as an imager, I'll say, well, this is really quite remarkable how good that image quality is given the size of the patient. Here it is in color. And there's no coronary calcium. He did have hepatic steatosis, so we made that diagnosis on the CT scan. And so we have, and here's his flow reserve. His coronary flow reserve is normal. So we've interrogated his heart very well. We've ruled out obstructive and non-obstructive coronary artery disease. We've gotten a prognostic feature here, and his ejection fraction was low, as I mentioned. Now, the same day, I had a patient who also had a BMI of 48, also a man, 60 years old. He was referred for a coronary CTA for recurrent chest pain. He'd had a stress test in the past that was a bit equivocal. His heart rate is 60, so at least he's a better candidate in that regard for a coronary CTA. And he does have mild coronary calcium known from previous before. We optimized the protocol for high BMI, and this is what we got. So despite our best efforts, it's a bit of a grainy study. You can sort of see this does not look like the type of images people usually show at conferences about to how good coronary CTA is. Here's a laid out view of the right coronary artery. It does not look obstructive, but it's not particularly pretty. And here's the LAD. There is calcium there. We ended up doing a CT-FFR to kind of confirm that it was non-obstructive, and indeed it was. There's a blow up of it. So on the left was the first patient of the digital PET study. It was unequivocal, normal perfusion, ejection fraction 27%, calcium score of 0 with normal flows, versus the coronary CTA and same BMI. It was a bit equivocal with marginal quantity. We needed a CT-FFR to make it convincing. The radiation dose on the right was 12 millisieverts. And the radiation of the dose was less than 3, on the left was less than 3 millisieverts. So that's how we're now using this new piece of equipment. Rather than perform CT scans in patients who are challenging that might otherwise have done it in, we'll switch over to a PET scan, basically because of radiation, especially in the younger patients. Let me talk now in closing a little about myocardial blood flow with SPECT. It's exciting and emerging, and I believe that's the future of nuclear cardiology, is to be more quantitative with PET and SPECT. So far, it's being done by a handful of centers in the United States. It's being done more frequently in Europe. And in this case, it's usually done with a fast acquisition camera, CZT camera. The images are acquired during stress, and then again after equilibration. And it helps, in some places, it helps to obviate the need for a rest image. So if the static perfusion images at stress are normal, if the flow at stress is normal, the quantitative flow of stress is normal, then maybe you don't need a rest scan. But anyway, I believe this is the future. So far, we've shown that it does correlate reasonably well with PET flow, but some more work is needed here. Standardization, perhaps the introduction of routine motion correction is one thing I've heard. So in closing, remember the prognostic value of exercise testing, the contemporary SPECT equipment, and the addition of coronary calcium score assessment contributes significantly to accuracy and prognosis. The better spatial resolution and higher accuracy of PET give it a distinct advantage over SPECT in a number of patient subgroups. And PET flow, and hopefully in the near future, SPECT quantitative blood flow, is powerfully prognostic, likely transforming the way we practice cardiology. Then I'll say thank you very much for your attention, and thank you again for inviting me.
Thank you so much for that great lecture. It's so, I think the new technology in nuclear cardiology is so promising. So please, everyone, if you have questions, put them in the QA and we'll go over them. And Dr. Garcia and Dr. Travinel joining us as well for the Q&A. Dr. Garcia, would you like to start with a question?
Sure. I first of all want to say thank you, Randy, for such a comprehensive overview and for a window to the future, and also for everything that you have done for the cardiac imaging, so specialty, actually a specialty, I would say. I like your quote about sliced bread. I agree with you. I think it's better to buy the bread as a whole and slice it at your taste. I particularly like to slice my thin. Others may like to slice it a little thicker. Use that as an analogy. I think, you know, that the place to draw the line depends a lot on availability of equipment, insurance company policies, and so forth. I do want to say something as a CT scan aficionado, but I do want to say something in favor of what you presented today, and is that I want to remind most people that the majority of the studies that have done comparisons have looked at patients without prior CAD, and in that category, you tend to evaluate patients that are more on the left side of the spectrum, whereas certainly patients that are on the right side of the spectrum are definitely territory for functional imaging, such as Spectre PEC.
I agree. So.
Thank you very much. So I think one question that I have is something that you mentioned. I read your statement from the guidelines and the concern for test substitution and what should the, you know, if you give all the options for different tests, I think the concern is for the insurance companies to dictate the practice. I was wondering if you wanted to comment on that, or what the approach of the agency is against that. And
right, and in fact, we have a multi-center, multi-specialty, excuse me, document in JACC that came out a couple of weeks ago about this issue of test substitution, and the organization that I'm representing, ASNC, is trying to push back hard against that. It's you know, the people that should make the decision about which test should be us as doctors. We train a lot. We understand the subtleties. There's the issues of contraindications and nuances and availability, as Dr. Garcia was saying, availability and expertise. And there's not really a strong signal that one test is better than another, and for very, very many patients. And we generally understand those. We understand these kind of subtleties. We ought to be the ones making the decision, and not the insurance companies. And that was one of the concerns we had about the new chest pain guidelines, is that it gives, it's pretty generous towards CTFFR. It may give insurance companies who've invested in CTFR, for example, the excuse to test substitute. And we think that's not right for the patients and not right for our medical system.
it's a good point. A question from Jonathan Leipzig. Thank you for joining us, Jonathan. It says, great talk. What about left main disease? Are you not concerned about left main uncertainty, especially post ischemia trial?
Well, what we do at our center is routinely, we do a fair number of coronary CT angiograms. I'm a CT enthusiast as well. When we do routine testing, our most common test would be a myocardial perfusion imaging study plus a coronary calcium score. And if someone especially on a high quality myocardial perfusion imaging study has no ischemia, the calcium score is low, then we then we've got confidence the patient does not need catheterization. Likewise, if that's the other reason I like about the flow reserve, if the flow reserve is normal, then the odds of severe left main disease or equivalent is nice and low. So that's one of the big advantages of flow and flow reserve, is that you can have confidence that you're not underestimating disease and missing severe disease like Dr. Leipzig's asking about.
Perfect. The other question, I don't know if Dr. Travin, do you have any questions?
Yeah, I mean, I would just say something. You know, some people say because of the ischemia trial, that the idea is we've seen a lot of retrospective studies that show a particular cutoff can decide revascularization, including the Patel study, Krishna Patel you just mentioned for PAD. But ischemia tried to look at this prospectively, and it didn't give the results that people thought. And some people may say, well, this ischemia trial has shown that these non-invasive tests are not worth doing. So I just want to see how you would respond to that for the audience to hear.
My take on the ischemia trial is that you don't need to rush to the cath lab, and that at least for mild to moderate ischemia, that medical therapy is good, and I'm not sure the answer has been found for severe ischemia. There weren't that many patients in the ischemia trial that truly had severe ischemia, and that the study had to go outside the US, where treadmill exercise tests were used to bring more patients in, especially into the severe ischemia category. So we may not have answered the question to the severe ischemia group. And if you think of the advances in medical therapy, and if it has simply shifted that cross point that we've been talking about for a long time, that would still be consistent. But I think most of us have understood for a while that you ought to go by symptoms. That if someone has severe ischemia, you probably it may be a little bit different than what the bottom line of the ischemia trial says, and I think that's probably what a lot of folks have concluded.
Yeah, I think it's hard to design these trials because people with a lot of ischemia, it's hard for somebody to allow those patients to be randomized
Right.
to see what happens to them. So a lot of these trials, the patients that eventually get in it, or like Scott Hart or something, they're not the type of patients we see, and they don't always do the tests we see. So it's very hard to put these trials together to prove these things, to show that these have clinical utility, right?
And for patients that are like those who are in the ischemia trial, medical therapy is good. Medical therapy, it's actually a fairly low risk population unless you've got some other issues and so forth. And medical therapy is good, and you ought to mostly let symptoms drive your treatments.
Mm.
And I do think there's still a role for diagnostic testing because including ischemia testing, because medical therapy is hard to motivate the patient and the doctor to do the hard work of optimal medical therapy. Takes knowing what you're dealing with, I think, usually to inspire people to do the hard work.
Good point. Thank you very much. I think one more question that I have is about the prior authorization. You know, we all know how cumbersome this is, and I know there's a lot of push by different societies into taking this away, right? Or this whole process of prior authorizations. And do you know if this is possible? What do you envision that will happen with that?
Well, the insurance companies don't seem to be getting less onerous in their prior authorization requirements. One issue with calcium score I mentioned is that one of the barriers to doing that is that it's generally not paid by insurance, and our hospital leadership doesn't always understand the fact that it's something you ought to do maybe at a low price or a loss leader or whatever. At my center, during the Great Recession, our hospital leadership reduced the price to $50 for a coronary calcium score, and we do it routinely with the myocardial perfusion imaging studies. And you know, most people don't have a problem with the $50, and I doubt we go after it very hard if someone doesn't want to pay the $50. And that was a solution, but most places don't want to do that. The price of the cost, incremental cost of adding a calcium assessment when you've done an MPI test is pretty low. The patient's already there, they've already checked in. You do the scan, you add it, and so forth. But that's a kind of a special issue that's I think an unfortunate barrier to something that would be helpful for our imaging. We generally Medicare patients do not have a problem with insurance coverage for PET scans. More of our patients with undergoing PET tend to be the older ones. But during the pandemic here, when we're doing pharmacologic stress anyway, we've been able to shift more patients from SPECT to PET. PET's a better test if you have to do pharmacologic stress anyway. And the insurance companies have generally cooperated enough, at least during this pandemic kind of time of emergency.
That's great. Do you think is there any concern with the change into more CT and the change in the guidelines of lowering the reimbursement for all different modalities? Do you think that's are we in danger of that or not?
I guess we'll see. You know, I mean, my point of view is that we, as imagers and as cardiologists, use all the tests. You know, every test has its advantages and specific use in certain patients. And I use all of the modalities that we have, as I'm sure you do.
Yeah.
Whether reimbursement will, you know, it's always an issue. Folks think we spend too much on healthcare and are always looking for ways to lower the price, and the things we do are kind of intensive and cost heavy.
Yeah, that's why I really like that study that we're quoting on the flow and the importance of medical therapy versus revascularization, and showing the value that these tests can add, right?
Yeah.
Great. Okay, thank you very much. Thank you. Great lecture.
Thank you again for inviting me.
Okay, we'll see you.